afternoon and welcome. My name is Marie Janice, and I'm the Executive Director of Equity and Community Health at CalOptima. Today's workshop will focus on heart failure is not the end of life. This course will discuss the definition, prevalence, and causes of heart failure. It will also explain the tests to confirm the diagnosis and the classifications of heart failure, along with its medical and surgical management. Before we go into our program, I would like to go over a few housekeeping details. Unfortunately, the presentation slides are restricted and will not be shared, but today's course is being recorded and the recording will be available for 3 to 4 weeks after the training. If you have questions during the presentation, please enter them into the chat box. Dr. Daji will address all questions at the end of the presentation. All participants will receive 1.5 continuing education units for this webinar. To receive credits, the attendees must first complete and attend the full session, complete the evaluation. Unfortunately, we cannot grant partial credit. And if you join by calling in, please let our team know by emailing to continuingeducation@caloptima.org inbox so you can get the credit for attending this. And again, when you're completing the online course evaluation, please allow time after the training to complete the evaluation. It should pop up on your screen after attending and the training. And if you missed the survey at the end of the workshop, you will receive a follow-up email that will be sent to you on the next day. And again, continuing medical education, the CME certificates, they will be sent to you via email by UCI School of Medicine Continuing Education Office after you complete the evaluation, and allow us up to 8 weeks to receive it. The nursing continuing education certificates will also be sent via email, but it will come from CalOptima Continuing Education team after you complete the evaluation. It will also take about 8 weeks. So now let me tell you about Dr. Himit Daji, who is our speaker today. Dr. Daji is a medical director at CalOptima Health. He is a diplomat of the American Board of Thoracic Surgery. Dr. Daji completed his undergraduate at the University of Cape Town in South Africa. He also obtained his medical degree from the Royal College of Surgeons in Ireland. Dr. Daji then pursued his cardiovascular and thoracic surgery training at UCLA. Dr. Daji practiced his surgical skills for 25 years in Southern California and has been in managed care for the past 17 years. Dr. Daji has received numerous academic awards and has co-authored 21 papers published in prestigious medical journals. He has also authored 2 books, A Boy Named Courage, A Surgeon's Memoir of Apartheid, which I have read and totally enjoyed, and your amazing Itty Bitty Diabetes book, 15 Key Steps to Understanding, Managing, and Living a Full Life with Diabetes. So without further ado, here is Dr. Daji.
Hi, good afternoon. My name is Himit Daji. I've been working here at CalOptima, and I can tell you our mission here is to serve the member health with excellence and dignity and respecting the value and need of each person. And I think that's very important to remember. So my topic is heart failure is not the end of life. It's fascinating when you talk to patients and their family members, when you say you have heart failure, they suddenly go into a convulsion and they think they're going to die that week or maybe that weekend or soon. And I think that is something very disturbing for the family and the family members and relatives. And so our job is to explain to them what is heart failure and what is it involved. So, let me just go back. Okay, there we go. So, the definition, first of all, of heart failure is that the heart is really a muscular pump. And I have a model here to show you. And you can see after the heart, the blood comes from the lung through into the left atrium first, then it crosses the mitral valve, then into the left ventricle, and you can see how thick that wall is of the left ventricle. Then it goes across from the left ventricle into the aorta, and it then goes down to the rest of the body and comes back, returns via the superior and inferior vena cava into the right atrium, crosses the tricuspid valve into the right ventricle. You can see how thin the wall is. And then from here, it goes across to the pulmonary artery and back to the lungs to be oxygenated. And you can see there are 4 valves. The 4 valves are all one-way valves, and it can only allow forward flow unless the valve has some disease process, and then you start developing symptoms. And what happens is when the heart starts failing, compensatory mechanisms are initiated to supply the blood to the vital organs. And what are the compensatory mechanisms? One is the heart starts stretching, the heart muscle starts stretching, and this results in ability to pump the blood across. Then over time, the heart muscle hypertrophies and increases the muscle mass. And ultimately, it then allows to meet the oxygen demand for the person. The actual pumping mechanism, over time, what happens is the fluid will start, as time goes by, the heart starts becoming weak because the fluid starts building up. There's retention of fluid. And to maintain circulation, the vessels start vasoconstricting, and this results in retention of sodium and fluid or water, and this results in early symptomatology. And as time goes by, there will be definitely a reduction in cardiac output, and this results in congestive heart failure. So what is the prevalence of heart disease in the United States? In US, 6.5 million over the age of 20 years and older have heart failure. And by 2030, it'll be increased to 8.5 million. And you can see that obesity, particularly, and hypertension. Now, as you know, hypertension is a silent disease, and the combination of two increases the heart failure, and it's a epidemic at the moment in the US. And annually, we find that almost 700,000 patients die from heart disease annually, and about 300,000 die from heart failure. 1 in 4, in other words, if you look at the number of people around you sitting around the table by you, 1 in 4 of you will develop heart failure in your lifetime. I mean, that's a given because we have such bad habits of eating and not being active. Interestingly, 20 million have asymptomatic cardiac conditions. It's like diabetes, you know. You have a pre-diabetic phase, which is asymptomatic, and then, of course, bingo, you become a diabetic. So same thing with congestive heart failure or heart disease. 20 million are asymptomatic. And interestingly, most of the deaths in the US is from the South and the Southeast. That is around Georgia, Alabama, Mississippi, Tennessee, those areas. And I have a theory why it's prevalent there. One, they eat a lot of fatty foods, and the other one is too much bourbon. The other interesting facts about prevalence is the fact that 8 patients out of every 1,000 males aged 50 to 60, about 60 years, have CHF, and 66 per thousand between 80 and 89 will have prevalence of heart failure. And it's like a car, if you don't maintain the car, it starts falling apart. Similarly, if we don't take care of ourselves by appropriate eating habits and exercise, we all will end up with increasing heart failure. Heart failure in men doubles every 10 years after the age 65. And in women, for the same cohort, it triples. And heart disease, particularly in men, is much higher and CHF than women worldwide. What about the race and ethnicity? Interestingly, African American men have 70% higher risk of heart failure compared to Caucasians, and in women, 50% higher risk of heart failure compared to Caucasian women. American Indians, on the other hand, they are 3 times more likely than Caucasians to have diabetes, and similarly, Hispanic women, twice as likely to be diabetic. And as you know, diabetes is a risk factor for heart disease. What about Asian population? CHF are 10 years younger than Caucasians. Also, myocardial infarction occurs at a younger age by 5 years, and diabetes develops 10 to 12 years earlier than other populations. They also have higher cardiovascular risk factors, and despite the fact they have lower BMI, you'd think that they'll be protected. No. The reason is because in Asians, the fat accumulation is within the abdomen. You won't see people with big bellies because most of the fat is within the abdomen. What about genetic studies in Asians? There were studies done in Asians particularly, and they noted that they had higher levels of LPA, which is a lipid level in the blood, and it's associated with greater risk for heart disease and stroke. They also have lower levels of certain stem cells, and they have the decreased ability to repair impaired blood vessels because of the low level of certain stem cells. Diabetics also develop heart disease more frequently. Jardiance, which is one of the SGLT2 inhibitor, fascinatingly increases levels of stem cells. And why is this important? Because it heals the cells when it's diseased by diabetes. Obesity drugs such as Ozempic and Wegovy has been shown to increase stem cells and thus reduce cardiovascular complications. Of course, this will only be proved over time, but this is the initial studies they found recently that these drugs do help patients who are diabetics. So let me go back to that slide, LPA. Interestingly, they found that LPA, there was a study done in Cleveland Clinic by Dr. Nissan, and they've shown that the nucleic acid therapeutics actually is now in a study where they design the nucleic acid to silence the LPA gene, And this reduces the elevated LPA levels and the harmful effects. The nucleic acid acts by degrading the messenger RNA that codes for LPA. The most fascinating thing is that at the moment, there are 4 trials going on. 2 of them will be coming out next year, 2025. And the 2 drugs that are being talked about are pelacarsen and lipodisirin. These 2 drugs, actually, they do lower LPA. And it's been shown that all 4 of them, by the way, will be injectables. And particularly lipodisirin will be able to be given just once or maybe twice a year. And that will lower your LPA level. When they were doing the study, they had almost about 48,000 patients from 6 continents, and they showed that only 14% of these patients had LPA levels taken. And Dr. Nissan said that that is totally inappropriate because when these drugs come out, you don't want to start testing them for the LPA levels then. You should be starting to do the LPA levels now, so by the time these drugs come out, you'll know who to treat more efficiently and in the early part of the game. So let's go to symptoms now. What are the symptoms of heart failure? Dyspnea, it is shortness of breath. It can either occur with minimal activity, or it can occur while you're in bed and sleeping, and suddenly you can get shortness of breath. You have to get up and gasp for breath, and you feel like you're getting smothered, and that's called paroxysmal nocturnal dyspnea, PND. The other symptoms are edema. You can get gaining of weight, anywhere between 2 to 4 pounds, and this because there's retention of sodium and water or fluid. Most of the edema is around the lower extremities, the abdomen, and in the liver. You also get chest pains. Of course, chest pains can occur with coronary artery disease and also without coronary artery disease, because as the heart fails, the heart muscle stretches and the subendocardium gets ischemic, and you get chest pain from that alone. Fatigue. The reason you get fatigue is because of low cardiac output. And when you have low cardiac output, there's diminished blood supply to your muscles and to other vital organs, and therefore you become tired and you don't have any energy. Palpitation is irregular heart rhythms, and a cough. Cough sometimes is also tinged with blood, and that's because of pulmonary veins sometimes leak blood into the alveoli, and it irritates the lungs, and you start coughing, and the sputum is rather frothy and also sometimes blood tinged. So what are the causes of heart failure? The 4 most common ones are ischemic heart disease, that's coronary artery disease, high blood pressure, diabetes, valvular heart disease, which is whether it could be from degeneration or rheumatic heart. Rheumatic is still the largest number of population around the world. Degenerative valve is because of advanced age, the heart valve starts degenerating, and they can either get a papillary muscle rupture, or you can get the caudal rupture, and that can give you valvular leak, and it can be either chronic and slow degeneration resulting in slow development of heart failure, or it can be acute, where you get a sudden rupture of the chordae that attaches the mitral valve or the papillary muscle, and you get acute regurg, and that can give you acute heart failure. The other causes are overweight, greater than 30 BMI, substance misuse, such as cigarettes, drugs such as opioids and cocaine, not opioids, sorry, cocaine and methamphetamines, and congenital heart disease can also give you heart failure. Cardiomyopathy, such as hypertrophic obstructive cardiomyopathy, Chagas disease, which is more prevalent in South America, and hemochromatosis, which is an infiltrative disease, including amyloidosis. The other causes are pulmonary embolism, which affects primarily the right heart, sepsis, and which includes endocarditis. Sepsis really causes inflammation and affects the entire heart. And when you get infection of the valve, it's called endocarditis, and it affects particularly the aortic and the mitral valve. And in patients who are drug addicts, you get endocarditis of the tricuspid valve because you're injecting the from the dirty needles, you get infection of the right heart valve, particularly the tricuspid valve. The other causes are arrhythmia, irregular heart rhythms, pulmonary disease such as COVID and other viral diseases such as influenza, RSV. These viruses are all inflammatory, and you get severe infection of the heart and reduction in cardiac output. You can also get heart failure from chemotherapy drugs such as adriamycin, for example, and neurodegenerative disorders such as Friedreich's ataxia. How do you misdiagnose heart failure? In other words, what's a differential diagnosis? For example, when you have renal disease, you get suddenly, over time, or suddenly fluid overload. And this can mimic as if you have heart failure. And patients will have rounds in the base of the lungs. They can also have edema of the ankles. So that you can confuse renal disease with heart failure. Also, venous and lymphatic obstruction can give you edema. Pulmonary disease such as asthma, fibrosis, chronic obstructive disease can also be confused with heart failure. And severe anemia, where you get tachycardia and shortness of breath, fatigue and weakness, can also mimic heart failure. And of course, cirrhosis. And in heart failure, cirrhosis is particularly in right heart failure, you can have cirrhotic liver. So what are the risk factors for heart failure? As I mentioned previously, advanced age, particularly 65 years and older, family history of heart failure, high blood pressure, sleep apnea. And in sleep apnea, you get desaturation and release of catecholamines, and that can be deleterious to your heart function. You can get vasoconstriction. Dietary indiscretion is very common and prevalent in our society, and particularly fatty foods and processed foods are notorious for causing coronary artery disease and other cardiac diseases. Arrhythmia, whether it is due to aging process or whether it's drug-induced. Sedentary lifestyle. This is a big one, by the way. As you know, we nowadays have so many gizmos to play around with and couch potatoes. They have all this screen time. So what happens is they don't go out and do any exercise, so it results in increasing weight gain and also lack of exercise. So what happens is you suddenly become uh, 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 your muscle becomes atrophied over time, and you lose muscle mass if you have a sedentary lifestyle. And of course, substance misuse, which I talked about earlier on. How come I can't advance forward? Am I doing something wrong? Oh, there you go. Sorry. Let me go back. There you go. Complications. So some of the complications uh, of heart failure is cardiac remodeling. For example, when you get a heart attack or myocardial infarction, what happens is that wall is no longer contracting, and you have sometimes bulging outwardly, and that happens in a left ventricular aneurysm, or aneurysm for that matter, of any of the areas of the heart muscle. And that aneurysm is scar tissue. So what happens is the geometry of the heart muscle changes, or the heart changes. Valve dysfunction similarly. You get, say, for example, you get severe regurgitation or severe valvular stenosis, like the aortic valve stenosis. The heart starts dilating, and as the heart dilates, the annulus of the valve also dilates, and that results in geometry of the heart changing. And instead of a triangular heart, you now get a globular heart. And particularly with myocardial infarction, with the alveolar aneurysm, the heart will be a boot-shaped heart. The other complications are renal deterioration, because you get decreased blood flow to the kidneys, and you start developing lower the GFR, glomerular filtration rate, and you get increased BUN and creatinine. Arrhythmia is not an infrequent phenomenon, and you get sudden death. Liver damage, again, I mentioned earlier on, right heart failure can give you liver damage. You get cirrhosis, for example, and pulmonary hypertension. As you know, most of the right heart failure is from left heart failure. And what happens is over time, you get marked increase in blood flow and pressure within the pulmonary system, and you get pulmonary hypertension, and it affects primarily the right ventricle. Malnutrition. Over time, what happens is patients with heart failure, because of the low cardiac output, and because you're no longer becoming active, you start losing muscle mass, and you go into a negative nitrogen balance. And what happens is you lose appetite. You also have a lot of fluid within the GI tract, so you are perpetually you have fullness in your abdomen, and you lose appetite. You can't eat. Thrombosis. Patients with heart failure have dilated heart, and they are actually at risk for forming clots within the cardiac chambers. And if it's on the left-hand side, you'll get a stroke. On the right-hand side, you can get pulmonary embolism. So how do we prevent heart failure? The most important one is to remember, don't be a couch potato. Be active. And, exercise is the most powerful longevity drug. And you don't need a prescription from the doctor. So be ready to start exercising after this talk. Adequate sleep is another important. You must have a sleep pattern which is not disturbed by anything in the middle of the night. And usually you want to have more than 8 hours sleep. Healthy, balanced diet. You know that we eat too many fast foods, too many processed foods, and too many meats. Cut out a lot of the meat, and you'll be surprised. Eat more fish, and with omega-3 fatty acids. The other preventative measure is to avoid smoking, avoid drugs, even, by the way, cannabis, which is a vogue nowadays, and it's been approved by many states. It's not a safe thing to do because it's now been shown it can cause coronary artery disease. Weight control, I mentioned before. It's important to keep your BMI for your weight and height. Also, taking the medications in a timely fashion. We are always busy running around, traveling, and what happens is we forget to take our drugs because of our fast life. And unfortunately, many patients, they end up in the ER, and you ask them what happened. They'll tell you that either they forgot to take their medications or they even forgot to refill their prescriptions. And that's really a tragedy. Reduce stress. Obviously, stress is healthy in some situations, but reducing stress at all levels is healthy because it lowers your catecholamine levels, and because elevated catecholamine levels will cause vasoconstriction and increases the stress on the heart. Also, make sure that you have recommended vaccinations. Vaccinations for flu, for COVID, and for all other vaccinations which are like RSV. And don't forget, even a flu symptom, and people who have severe flu infections from influenza, by the way, you do get MIs from influenza. And that's been shown categorically time and time again. So it's good to be vaccinated. So what are the diagnostic tests available in patients with heart disease or heart failure? First of all, the blood work. You want to do comprehensive metabolic panel, including electrolytes, particularly sodium, potassium, and troponin levels, BNP or natriuretic peptides, urine drug screens to rule out any evidence of cocaine or amphetamine intake, liver function test. As I mentioned earlier on, you can get abnormal liver function tests and renal tests to check your GFR, BUN, and creatinine. The interesting thing is that in 1981, BNP was isolated, and they now found out that the heart is not only a pump, but it's also an endocrine organ, and it secretes BNP. The other test you can do if you have irregular heart rhythm, whether it is intermittent or like paroxysmal, Holter monitor and event monitors can be used to test for any abnormalities. Chest X-ray will either show you several things. It will show you calcification of the aorta. It will show you whether you have wide mediastinum or the heart size, whether it's globular or whether there is shift in the mediastinum. All these are important findings on a plain chest X-ray. Even aortic dissection will show you a wide mediastinum. And in heart failure particularly, you will see either infiltration of the lungs or you'll see fluid levels within the pleural space. EKG is important because that will tell you about the rhythm of the heart and will show you any Q waves, which would be old infarcts, or ST elevation, which is a new onset of having acute MI, and echocardiogram. There are two types of echocardiogram, such as transthoracic, and that is where echocardiograms are really an ultrasound, and you can do it across the chest from the outside. And the only problem with echocardiogram is the lungs sometimes interfere with the visibility of the cardiac chambers and sometimes the valves, and therefore some recommend a transesophageal echocardiogram, where the endoscope is guided into the esophagus and positioned just behind the left atrium. So the lungs are no longer in view, and you can see much better. You have clearer view of the valves and the function of the heart muscle. The echocardiogram will show you the valve, whether it's leaking valve or stenotic valve. It'll show you whether there's intact papillary muscle or caudal rupture. It'll show you wall motion of the heart, and it'll also show you any abnormal clots within the cardiac chambers, particularly in heart failure. The next test you can do is cardiac catheterization, where the cardiologist will puncture the femoral artery and will guide the catheters up to the heart and inject dye within the coronary ostium, and will show you the anatomy of the coronary arteries and both the left side and the right side blood supply. And you can either do it through the groin artery or you can do it through the radial artery. And if you do it through the radial artery, you can get sent home immediately. Where if you do the groin puncture, you have to stay in the hospital at least 4 to 6 hours to make sure you don't have any slow leak in the groin and result in a hematoma or a false aneurysm, which will require intervention. The other test you can do is EP study or electrophysiological, particularly when you have atrial fibrillation or any other aberrant rhythm which causes heart failure, such as SVT or supraventricular tachycardia. Stress tests. There are several kinds of stress tests. The most easiest one is a treadmill test, and you run on a treadmill and you can see whether you have any EKG changes and whether there's ST elevation, or you compare with your symptoms. And as you run on the treadmill, they'll increase the steepness of the treadmill and also the speed of the treadmill. And as you increase both, your workload will be increasing. In other words, your heart has to pump faster and harder to circulate blood so it can meet the demands of the muscles, and you can get chest pains. And of course, if you get chest pains or dizziness or shortness of breath, it'll alert the cardiologist to either to terminate the test, and you can also do other sophisticated tests, which is nuclear tests, where they inject nuclear material into the body, and you can see the wall. The nuclear material will go into the coronary arteries and supply the muscle, and you can see whether there is any deficit in the area of the muscle, which will show you either a infarcted area, whether it's new infarct or old infarct, which will be just scar tissue. So there'll be no uptake in that area of the nuclear material. And the other tests you can do are myocardial biopsies, particularly in transplant patients, where you want to see whether the patient is developing rejection or is there really any other pathologies, even heart failure patients. You want to do, particularly in patients, for example, in amyloidosis or in iron overload, you can do a myocardial biopsy. The other test you can do, and this is getting down into the expensive, more expensive areas, such as CT scan. the CT scan of the cardiac muscle. You can do calcium scores to see how much of the calcium burden is there in the heart and how much atherosclerosis burden there is. You can also do an MRI of the heart as well, which is magnetic resonance imaging, which is doesn't there's no ionizing radiation at all. Then you can do genetic testing. For example, if the patient has heart failure, acute heart failure, say, for example, due to aortic dissection, because don't forget, it's familial, and some family members can have silent, like Marfan syndrome, and you can do genetic testing to make sure that other family members don't have the potential for having Marfan's disease, which can develop aneurysms and rupture. So how do you classify heart failure? There are two systems. One is the New York Heart Association classification. It's based on the physical activity limitations. And there are four. Asymptomatic, that's one. New York Heart Association classification 2 is daily activity is possible, but you will have some shortness of breath and fatigue with exercise. Level 3 would be you cannot complete your daily activities, and 4 is severe shortness of breath even at rest. The next classification is the American College of Cardiology / American Heart Association classification, and this is based on the risk of developing heart failure. And there are 4 stages. The first 2, you do not have to have any signs or symptoms of heart failure. But with stage A, you have risk factors for heart failure. And in B, you actually have heart disease present, but it's silent. Stage C is where you have heart disease present with positive signs and symptoms of heart failure. And stage D, it's advanced heart failure, and you need specialized treatment. What are the other classifications of heart failure? The first one is left-sided heart failure. This particularly affects the left ventricle of the heart. The blood stagnates with heart failure in the pulmonary veins and left atrium, and you now get shortness of breath and cough. First of all, there are 2 kinds. There's systolic heart failure and diastolic. Systolic affects mainly the left ventricle, which contracts poorly. And with heart failure, you get reduction in ejection fraction, which is below 40%. And that's why you can see in brackets, you can see there, HFR is for reduced and EF for ejection fraction. HF is heart failure, R is for reduced, and EF is ejection fraction. For example, heart attack, MI, hypertension, valve abnormality as myocarditis can result in systolic heart failure. On the other hand, diastolic heart failure is different. In diastolic heart failure, the left ventricle is unable to relax. Therefore, the filling is impaired. In other words, the blood coming back from the lungs into the left atrium and then across the mitral valve into the left ventricle is not able to fill the blood in the left ventricle because the left ventricle is not able to relax. There's stiffness of that left ventricle. And in these patients, the ejection fraction is usually preserved. That's why it's called HFP is for preserved and EF is ejection fraction. Examples are, again, high blood pressure, coronary artery disease, diabetics, and obstructive sleep apnea. All these cause diastolic heart failure. The next one is right-sided heart failure. Here, the right ventricle is unable to pump blood to the lungs, and it retains fluid primarily in the abdomen, lower extremities, and liver. And the right ventricle failure results in the most commonest cause, of course, right heart failure is because of left ventricular failure via volume and pressure overload. In other words, pressure overload means, for example, in pulmonary embolism, in acute respiratory distress syndrome, pneumonia, congenital heart disease, and pulmonary hypertension, all this results in the right ventricle pumping against high pressure because you have occupation in the lung of either from the pneumonia or from ARDS. There is resistance for the blood to flow. That's why it's called pressure overload. On the other hand, volume overload is different. Volume overload, where there's increased blood flow, or blood volume rather, because of valve insufficiency. For example, when you have pulmonary valve leaking, tricuspid valve leaking, congenital heart disease with a shunt, atrial septal defect, and anomalous pulmonary venous return. All these result in increased volume load, and therefore the right ventricle goes into heart failure. Then further classification is acute and chronic heart failure. Acute heart failure is when you have acute heart attack or acute MI, you get arrhythmias, valve dysfunction, pulmonary embolism is an acute event, aortic dissection is also an acute event, and viral infection. Aortic dissection, you get acute heart failure because the valve can be detached and you get sudden aortic regurgitation. Your left ventricle suddenly dilates and causes acute heart failure. And you have to intervene urgently. And acute heart failure can also occur in endocarditis, where you can rupture the chordae or the valve attachments, and you can get sudden event and sudden leaking of the valve, and that's called acute heart failure. On the other hand, chronic heart failure is much more long-term. It's manageable with medication. It can be asymptomatic for some time. And other examples are coronary artery disease and hypertension. These are all slow process and causes chronic heart failure. So after having discussed all this, how do we treat heart failure? And what is the objective of treating these patients? The most important one is to relieve symptoms because the patients are very uncomfortable. And of course, medication management is the first method. The others are avoid complications, reverse the progression of underlying process, promote physical activity, and of course, there are other devices you can use to control rhythm, such as cardiac resynchronization, and of course, surgery. Surgery sometimes is useful, particularly in patients who have sudden death. And, in patients who have EF below 30 or 35%, they are at high risk for ventricular fibrillation, and therefore AICD is required or recommended. The other surgical intervention that can be done, or which is commonly done, is coronary artery bypass graft and valve correction, whether it's a leaking valve or a stenotic valve. Then there's congenital heart repair, and sometimes you end up having a heart transplant. Then there are mechanical pumps, which can also be used to treat heart failure and on the way to a transplant. And of course, finally, is end-of-life care. These are all different gradations of treatment objectives. So let's talk about the medications first. First one is angiotensin converting enzyme inhibitors, ACE inhibitors. And what do they do? They relax the blood vessels and lowers the blood pressure. So it lowers the strain on the ventricle. The angiotensin receptor blockers or ARBs. It also treats the blood pressure and heart failure. Then there are other drugs like angiotensin receptor inhibitors, such as it's called ARNIS, and this reduces the excess fluid and again relaxes the blood vessels. Beta blockers is very useful because it reduces the heart rate and the blood pressure. So all this is helping the heart pumping against stress, or reduces the afterload, in other words. Diuretics is primarily to reduce the excess fluid or edema, and it reduces the pulmonary overload. Potassium-sparing drugs such as spironolactone and eplerenone, it's useful in patients with reduced ejection fraction and those with severe heart failure. There are other drugs which are novel drugs, and it's been very useful, such as sodium glucose co-transporter 2 and inhibitors. These are Invokana, Farxiga, and Jardiance. And these are useful because, particularly for insulin-dependent diabetics and heart failure, it reduces heart failure hospitalization. So these are very useful and novel drugs that are now being used. Other medications are digoxin. It reduces heart failure symptoms, particularly in reduced ejection fraction below 40%. And of course, as you know, heart failure patients are at risk for atrial fibrillation because you have dilation of the atrial walls in the patient who have severe heart failure. Hydralazine and isosorbide dinitrate, these drugs, they relax blood vessels and it improves survival in people with reduced ejection fraction. Positive inotropes, these drugs are used to improve contractility of the heart muscle and maintains blood pressure, particularly dobutamine and milrinone. And these drugs are given in IV, and you can give some of these drugs peripherally, but you have to be careful. Sometimes you can get skin sloughing if inadvertently the drug, particularly dobutamine, extravasates into this subcutaneous tissue. So preferably it should be given through a central vein or through a what do you call it? I'm trying to think of it. It will come back to me in a minute. The other medications are anticoagulants. As you know, when you have poor ejection fraction and dilated heart and poor contractility, there's stagnation of blood within the chamber. And what happens is you get thrombus formation. And these thrombi can embolize and give you stroke, or it can go down the aorta and can give you infarction and blockage of the peripheral arteries, can give you gangrene of the toes, or it can also give you renal infarction if it embeds within the, one of the renal arteries. Anti-inflammatory systems such as systemic inflammation contribute to development of C-reactive proteins. And for example, interleukin-1, IL-1, is an inflammatory signaling molecule and plays an interesting role in the pathogenesis of heart failure. And this drug here, anakinra receptor antagonist, It improves oxygenation consumption and also improves the ventilatory efficiency and left ventricular ejection fraction recovery. But it does not reduce the hospital length of stay or rehospitalization for heart failure. Then there are other drugs such as colchicine, which is a very old drug. It's mainly for treatment of gout. But it was shown some time ago that there were, I think, about 12 or 1,400 patients who had heart failure, and over just about 300 patients had colchicine. And it was shown that those who had colchicine and heart failure, those patients had actually better outcomes and even reduced mortality than those patients who were not on colchicine being treated for gout. And that was a fascinating finding. And now, I was just talking recently to someone, one of the cardiologists, and I believe colchicine is now being prescribed in those patients who have inflammatory heart disease causing heart failure. So let's go to the treatment of different stages. In stage A, that means you're at risk for heart failure. Exercise is the most important way to treat, including abstinence of substances. In other words, your drugs such as smoking, etc. Treatment of hypertension, lipidemia, and diabetes. And of course, you have to include ACE inhibitors and ARBs. That's for stage A. On the other hand, if you have stage B, that is without signs of heart failure, again, you treat as if it's stage A, plus you include now ACE and ARBs, and also beta blockers, especially if you have an MI and post-MI. The other treatment is surgery, and usually is coronary artery bypass graft, valve surgery, or congenital heart disease treatment. For stage C, where you have heart disease with signs of heart failure, atrial fibrillation, for example, you treat them particularly with hydralazine and nitrates and diuretics, and again, aldosterone antagonists, particularly in severe symptoms. And you restrict sodium and water, and you have weight control. That's for stage C. Stage D, where you have refractory heart failure, you end up, if the patient meets criteria, with heart transplant or a ventricular assist device and other surgical options, which could be experimental. And then I mentioned earlier milrinone and dobutamine, such as continuous infusion, and these are IV inotropes I mentioned earlier on. And of course, finally, in stage D, you can have end-of-life care as another option. So what are the device-mediated treatments? They are ventricular assist devices and bridge therapy. Ventricular assist devices are mechanical devices to assist a weakened heart to pump blood. And these are inserted by the surgeon at the time of surgery, but there are also now a percutaneous approach that can assist the heart, and the cardiologist can insert some of these devices. The ventricular assist devices can be two types. Say if a patient has a need for heart transplant, but he has some abnormal blood abnormalities, and they have difficulty in cross-matching. So therefore, you have to wait for the appropriate donors to be sought. And what happens is you can then, while waiting for the blood to be to get a donor for it, that patient can have a bridge therapy. In other words, you put a ventricular assist device to assist the heart, because without the heart assist device, you'll die. So you put in a ventricular assist device to give you time to get the donor blood available, so the appropriate matching is there. And so that's called bridge therapy. That means you're awaiting a transplant. On the other hand, destination therapy is different. This is long-term and it's final. In other words, no transplant. These are not transplant cases. And therefore, this patient lives his life out with the transplant, with the ventricular assist device. For example, say a patient has some other chronic disease and you know he's going to die within a year or maybe 2 years, and you can put this ventricular assist device and you can live with it. And as long as you consent to it and you understand the meaning of destination therapy. There are other device-mediated treatments such as Barostim Neosystem. And as you know, in heart failure, what happens is the baroreceptors in the arch of the aorta and also in the carotid sinus, you have receptors that controls your heart rate. And these receptors, they actually become malfunction, and this device is like a little pacemaker with some leads, and they rebalance the autonomic nervous system by triggering the baroreflex. And it is being used, and it is FDA approved. Then you can have CardioMEMS heart failure system. This is where they position in the pulmonary artery a small device which is about a centimeter long, and it is located or inserted at the level of the pulmonary artery, particularly the right pulmonary artery, and the nitinol leads, they expand, and this system actually occupies about 10% of the lumen of the pulmonary artery, so the blood flow is still within normal limits. And what happens here is this device detects high cardiac filling pressures almost 2 weeks before symptoms occur. So in other words, before even your BNP elevates and before even you get symptoms, this device is able to pick up and will send the signal to the cardiologist and to his office, and he can then follow you, and they can intervene appropriately. They can change your drug medications and doses appropriately so you can keep you out of the hospital. What are the other therapies? They are regenerative therapies. In other words, you can induce pluripotential cells. In other words, what happens here is actually the patient's as you know that we all have cells or stem cells which have the potential to become cardiomyocytes. In other words, you can stimulate the skin or blood cells that can be reprogrammed to produce cardiomyocytes. And this has been done in animals, by the way. And so that's one therapy. The other one is cardiomyocytes. This is where regeneration of the cardiomyocytes that constricts the heart muscle, and you can manipulate the actual cell cycle of the cardiomyocytes, and you can convert them into a proliferative state. That means you can start manufacturing cardiac cells to be able to contract. And again, this is all done in animals, but one day it will probably be available for humans as well. And as you know, genetically modified pig heart transplants are now being done twice, I think, so far. And what they do here is there are 10 genes that they can manipulate. I think 8 of them are actually genes which are actually altered. In other words, they are they design, or rather alter the gene or genome in such a way that you don't have the antibodies forming when the pig heart is used. And the other 3 genes are where the heart of the pig doesn't keep growing. So you shut those genes off altogether. So therefore, these pig hearts can function within the heart. Now, the first one died. I think only survived for maybe a couple of weeks. The second one also died, survived a little longer, but that patient had a viral infection because the heart that they transplanted had some viral particles in there, which became active, and the patient died and the heart malfunctioned. So what's the prognosis of these patients with heart failure? And as you know, overall, you shorten lifespan if you have heart failure by 10 years. And at 1 year, 80 to 90% will survive. On the other hand, at 5 years, between 50 to 60% survive, and at 10 years, only 35% will survive. So it's a pretty grim statistic. So let me go back to the beginning again. Make sure you exercise, eat well, and live well. Any questions? These are some of the references that you have, you can read. And thank you for listening to me, and I would welcome some questions if you have any.
I have a question. I was curious when you were sharing the data on the regions of the country where the incidence of increased heart failure is related to the hypertension, the obesity, and also about the significant increase in African American males. And I was wondering if there's been any research on the impact of racial discrimination and the stress put upon people by having to live with discrimination on the effects of heart failure.
You know, I'm sure there must be some studies, but I can tell you about the other side of race. As you know, a lot of the, I'm not sure what percent, but a significant percent of Hispanics, of the American Indians, or even for that matter, African American population, they, don't forget, they don't have the, they live at a much lower federal poverty level. And so therefore they don't have access to food, they don't have access to parks and recreation areas. So in a way, you know, they're not discriminated, but they don't have the full complement of things that you and I have. And so therefore, these patients have a higher risk of heart failure and heart disease. And you're right. Sometimes, you know, when you are discriminated on a chronic basis, you get increased catecholamine levels, and that causes hypertension and heart failure. And I mean, this has been shown time and time again. And the other thing, too, is a lot of these people who have poor socioeconomic background, they don't have the financial resources to eat well and to eat the proper foods. And so they end up eating fast foods. And of course, to make them happy, because they're depressed, they imbibe alcohol. So, it's a vicious cycle, I agree. But that's, one explanation why you see a disproportion of patients having heart failure.
Is it true that you can die from a broken heart?
Oh, yeah. I completely forgot about that one.
Okay.
That's a Japanese heart disease, and it's called a broken heart syndrome. And by the way, you need not have any coronary artery disease. What happens is acute, let's say someone dies in the family or your spouse dies, that person can have acute anxiety, acute emotional disturbance, and you can get left heart failure. And the heart becomes globular. You can see the heart bulging outwards. And by the way, it's more frequent in women. 90% is in women and 10% in men. And the fascinating thing is, they all recover, by the way. None of them require surgical intervention. And it takes several months to recover. But that's I can't pronounce it, Takabutsu or something like that. I'm not able to pronounce it correctly. But you're right, there is an entity which is called broken heart syndrome.
Fascinating. Thank you.
Anybody else?
Hello, Dr. Dachi. If you look into the Q&A box on the bottom, you will see some questions on there. The first question is, can you please give examples of actual test result of how stress is healthy and marijuana is not?
Well, in stress, I'm not sure what you're really saying, but anyway, talking about stress, in stress you have increased catecholamine levels, particularly adrenaline, and that causes vasospasm. And on a chronic basis, that will be a stress on the heart pumping. And what happens is you get hypertrophy of the left ventricle. And over time, from hypertrophy, you get, coronary artery disease because of constant spasm. And ultimately, with chronicity, as the heart pumps harder and harder, and it cannot meet the oxygen demand. So what happens is the heart ultimately fails if nothing is done, if not corrected by either medications or by changing your lifestyle, whether it's eating appropriate food or not. And I'm not sure if I answered that question or not. And the other one was about marijuana. Yeah, marijuana does cause coronary artery disease. More and more articles are coming out, and people think, it relaxes you. But, a lot depends who's smoking it. And also, what else are you drinking with it? So, and what other drugs you're taking with marijuana? So you have to be careful. It's not just a single medication, but it's also the lifestyle that person lives can also affect your heart.
Thank you, doctor. And there's a next question. It says, what is the most successful regenerative therapy done to non-humans and that have been done to humans?
So far, I'm not aware of any regenerative therapy been done on humans. It's all been done on animals. So someone asked me to show them slide 7. Somebody asked to show slide 7.
My question was...
Thank you, Dr. Daji. This is Michelle from Noble. I appreciate it.
Have a blessed day. It's great to see you.
My question, Hemant, was who should be on Entresto? And they said show slide 7, but I don't.
Ooh, that's not slide 7.
Yeah.
Dr. Daji, this is Michelle Noble. The questions are not related.
Oh, they're not
I just
related.
missed
Okay.
slide sale.
Oh,
Thank you for displaying it.
Okay. Okay. Where was it now? Okay. I was talking about, or rather, somebody was asking me a question about Entresto. First of all, Entresto is those people who have severe heart failure, and also those who have, it's a drug that has been more frequently used, and it really is much more potent than the other two, and it's particularly in stage 3 or heart failure.
so do you wait till they get to stage 3, or can you use it at stage 2?
No, you're not supposed to use it for the early, and also you're not supposed to use it. If you're already on an ACE inhibitor, you cannot use Entresto. It'll affect you, and so it's only for those people who have not succeeded or improved on the ARBs and ACE inhibitors. Then you put them on Entresto.
Thank you.
Anybody else? Where's the other?
Dr. Dachi, there's a question regarding to exercise as treatment on stage A and B. Are you able to see that questions?
No, I don't know how to start where those questions are.
Okay, if you look in the chat,
Yeah.
you can see, let me read it to you. Regarding to exercise as a treatment on stage A and B, some studies have shown that anaerobic exercise, HIIT, weightlifting, etc., increase the productions of VEGF versus aerobic exercise, walking, running, etc. Would you recommend one over the other, particularly on patients with limited mobility due to comorbidities such as knee, hip arthritis, or other parts?
Yeah, let me just tell you, one of the things is when you're in heart failure, you do not want to do very heavy lifting. And that is a deleterious effect, because now what's going to happen is you're stressing your heart. So if you have no heart disease, the best exercise is walking or light weights. And particularly, don't forget, as you age, you also lose muscle mass. And in other words, you get sarcopenia. And to have a good physique, so you're able to walk and not fall down, you want to do exercise which involves some sort of stress or some limited amount of weight, maybe 10 pounds or 5 pounds. And so it's resistance exercises, for example. So those are the ones are preferable. Heavy lifting, and particularly when you're in heart failure, you're going to make it worse. Because, for example, when you do heavy weightlifting, for example, when you're laying supine and you're doing lifting weights, that's very dangerous for patients who are in heart failure. And also patients who are stooping down and lifting weights upright, that's also very risky in patients who are in heart failure, because you can make the heart failure worse. Because what you're doing really, you're increasing the afterload for the heart, and therefore it's not advisable. Key really, if you have a heart failure, depending on what stage, the best thing to do is to do light exercises. Walking is very good, and also exercise without weights, for that matter, like Tai Chi is very, very healthy. And the other one is Pilates. It's also very healthy. And so it'll keep you trim, and it will not put stress on your heart.
How about swimming?
Yeah, swimming is one of the best. Swimming and cycling, I believe, are the best exercises. The reason I tell you is because all the muscles are active.
Dr. Daji, I asked a question about exercise, and thank you so much for answering. My name is Jorge. I'm a health coach here at Calotima. So the question comes because some of my clients either have diabetes or heart failure. They also have other comorbidities such as knee arthritis or hip arthritis, back pain, and that prevents them from even walking. It's a problem. They cannot walk. So in those cases, is there any modified activity that they should try to, say, sitting? They can do some exercises that can help?
Yeah, swimming. If you can't swim, just get into the water and just do, exercise like stretching exercises and leg exercises, because you are weightless in your water, in the pool, and therefore you will not putting on any stress on the joints. So that's why swimming is very good and it's very healthy. It doesn't stretch your heart muscles. And the only thing that swimming does, it does increase your heart rate, but it's not deleterious for your joints.
Thank you so much, Dr. Daye. Sorry.
That's okay. So that's really the other part is, as you know, that the joints, as you age, your joints start becoming weak, and your muscles also are weak, and you tend to fall. So that's why you want to do exercises which increases your muscle mass. But you do not have to do heavy lifting to increase your muscle mass. You can, and that's important to remember. Not everybody has to, start lifting weights. The other important point is, it's been shown when you do cycling, it increases your lifespan by 7 years. There was an article some years ago in Lancet, and when I was reading it, I was totally perplexed that it actually increases your lifespan by 7 years. And that tells you can go to a gym, by the way, and just do cycling. And it's not a stressful activity. It doesn't destroy your joints like jogging. When you jog, don't forget, you're putting profound amount of pressure on your joints and your spine. And so that's why jogging is not healthy. And I see people jogging on the street. There's nothing worse than jogging on the street. You know why? You're inhaling carbon monoxide from all the cars that bypasses you, or that you bypass the cars. So to me, people who jog on the street, they should think twice. Go to the gym or stay in your house and do your exercise in the house.
Dr. Daji, this is Dr. Lin. When do you add SGLT2 to the treatment plan?
Particularly diabetic. And it helps two things. It helps lower your blood sugar, and it prevents heart failure, or it treats heart failure. So it's been used more and more frequently in those patients who are diabetics and those people who have associated heart failure as well, or early heart failure.
But you wouldn't use it for non-diabetic?
To my recollection, Jardiance is not used now. I'm not a medical person. I'm not a cardiologist, but I'm not sure you can use Jardians, because don't forget, if you start using, you're going to lower your blood sugar. So you have to be careful. You cannot use these drugs if you're non-diabetic, unless you've got heart failure and diabetes.
Okay.
But I may be corrected. In fact, that's a good question, by the way. But I know by and large, Jardiance is primarily used by people who are diabetics and also who have heart failure, and it can prevent heart failure in diabetics.
Thank you.
Dr. Daji, there's another question. It said, would you recommend taking A/ARB statin, baby ASA, and low dose beta blocker for heart protectant?
I would say that any medication that you take, you want to take it with your doctor's prescription. And I cannot tell you what to take. But the thing is that this talk was primarily about what drugs are available for anybody who has heart failure. And ultimately, don't forget, you have to be prescribed these medications.
And unfortunately, we run out of time. So I would like to respect everybody's time. I will email this question to Dr. Daji, and Dr. Daji will answer those questions, and we will email back to you. Marie, would you like to do the closing remark, please?
You're muted.
My favorite way to speak, muted. So thank you, Dr. Daji, for this great workshop, and my thanks to all attendees. We appreciate your participation. Please don't forget to complete the online course evaluation so you can receive your continuing education units. It will pop up at the end of this workshop. And again, if you missed the evaluation, a follow-up email will be sent to you the next day. A friendly reminder, and maybe a commercial, you can access our health and wellness referral forms, member interactive self-care videos, tools, and handouts through caloptima.org when you click on Health tab tips. Again, thank you very much. And you can email healthpromotions@caloptima.org if you have questions. Thank you, everyone, and have a very nice day.
Marie, could you put the
I will certainly, the email.
Put that in the chat so that we can do the questionnaire.
I will do so.
Thank you.
Thank you, everybody. Appreciate it.
Thank you.
Bye.
Thank you, Dr. Daji.
Thank you. Bye-bye.
So that's where we take the test, Marie?
No, that wouldn't be where you take the test. The test will actually pop up as you shut down your Zoom. And if not, you will receive an email with it. It's really a survey.
Okay. But that's how we get our CME, right?
That's correct.
Okay. Thank you.
Thank you.